Okay, so the mind map about the drugs with toxic renal effects is more of a summary of everything. So let's try and use this to brainstorm and remember everything that we can remember. So the complex nature of critical illness often necessitates the use of multiple therapeutic agents. So many of these drugs may individually or in combination with um, other drugs have the potential to cause renal injury, and the incidence of drug-induced nephrotoxicity is well documented in a number of drugs. So, drugs with direct nephrotoxic effects may induce renal injury by several mechanisms. So, drug-induced renal impairment involves many classes of drugs, so prescription agents and over-the-counter drugs. And some of these drugs include antimicrobials, NSAIDs, chemotherapeutic agents, and they are also drug, kidney, and patient-specific risk factors that influence the development of drug-related nephropathy. So, with drug-specific risk factors, the toxicity of therapeutic agents may be inherent in pharmacological compound itself, and this toxicity may be heightened in the kidney microenvironment. Okay, I hope you get this. All right. So, for example, the aim of chemotherapy is to kill malignant cells. However, healthy tissues, including in the renal parenchyma, can be affected. Okay, so that's for the drug specific risk factors. For kidney specific risk factors, the kidney is a target for toxicity because it receives a significant percentage of cardiac output, exposing it to drugs and drug metabolites. And the kidney also oxidizes drugs via cytochrome P450 and yields metabolites, which could have direct effects on renal cells. Right. So, in addition to this, certain therapeutic agents may gain potential um, toxic potential within the kidney microenvironment. For example, methotrexate, nephrotoxicity. Upon it depends upon crystallization of the parent compound and um, its metabolites in renal tubules. So this crystallization is highly favored with an acidic urine pH, which exists in the normal host. Alright, so the third has to do with patient-specific risk factors. So certain patients' characteristics can predispose one to drug-induced nephrotoxicity, and among these are old age and being a female. So these individuals have reduced muscle mass and low total body water. One thing that you have to realize is that this reduced muscle mass would translate to low serum creatinine, and depending on the type of estimations used, for example, the old EGFR formula, the glomerular filtration rate calculated may actually be false, can be high, leading to inappropriate high drug dosing, and decreased total body water also increases the concentration of the drug in serum. So both factors work in concert to raise the serum drug concentration to potentially um, toxic levels. So in addition, the rates of drug-induced nephrotoxicity is increased in patients with acute or chronic kidney disease. Similarly, the patients with hepatic failure is susceptible to nephrotoxic effects of certain drugs. So hyperbilirubinemia is also a predictive factor for nephrotoxicity because of renal tubular damage from bowel salts. Also, populations at risk for drug-induced renal injury are neonates, critically ill neonates using multiple nephrotoxic agents may be at higher risk. Alright, so for nephrotoxic drugs, these are drugs which, like I said, um, can impair renal function by interfering with renal blood flow, um, glomerular filtration rates, tubular fluid formation, and exit of urine. So, how many drugs have a single mechanism of injury? Some classes of drugs possess multiple ways of inducing renal dysfunction. Right, so, the nephrotoxic drug classes include antibacterials, NSAIDs, ACE inhibitors, angiotensin 2 receptor blockers, antivirals, antifungals, and chemotherapeutic agents. So with the antibacterial agents, some antibacterial agents like aminoglycosides, gentamicin, and amikacin, and the rest, they pose nephrotoxic effects. Also, sulfamethoxazole, trimethoprim, and sulfur-based antibiotics too, and vancomycin, ciprofloxacin, all these could. So let's take them one by one. So for aminoglycosides, they are well-known nephrotoxic and ototoxic agents, toxic affecting the inner ear, causing all these ear issues. So in spite of these risks, they are still widely used in the treatment of gram-negative bacteria infections, and even at therapeutic doses, the incidence of nephrotoxicity is reported to be as high as 10% to 25%. So aminoglycosides risk for nephrotoxicity is higher with prolonged duration of therapy. So neomycin is the most toxic drug in this group, followed by gentamicin, tobramycin, amikacin, and also streptomycin. So aminoglycosides actively concentrate in the renal cortex and proximal tubular cells. And one thing that you have to know, that after entering the cortical cells, the aminoglycosides bind to lysosomes with formation of myeloid bodies or in secondary lysosomes, and thereafter mechanisms are unclear. To prevent nephrotoxicity, drug doses should be calculated based on estimated creatinine clearance, either Cockcroft, GALT. It takes into account gender. So monitoring the peaks and trough serum aminoglycoside levels would also help to minimize risks, but this really done though. Alright, so for sulfamethoxazole, trimethoprim, that's Subtrin or Bactrin, and sulfur-based antibiotics. Sulfamethoxazole is probably the most widely used sulfur-based antibiotic, and is generally prescribed along with synergistically acting privatecoprem as a combination antimicrobial agent. So Subtrin or sulfamethoxazole trimethoprim is known to possess these renal adverse effects, and trimethoprim actually inhibits the proximal tubular secretion of creatinine and can result in elevation of measured serum creatinine, and also the use of high dose sulfadiazine. This can cause crystal nephropathy, but it really occurs in rare occasions. So vancomycin is a glycopeptide antibiotic. It's also commonly used in critical care settings, for example, methicillin staph aureus infections, methicillin-resistant staph aureus infections. I will give vancomycin to. So vancomycin-related nephrotoxicity is generally due to acute tubular necrosis or acute interstitial nephritis. So high trough levels, for example, more than 50 milligrams per liter, long duration of therapy, and concomitant administration of other nephrotoxins, for example, like the aminoglycosides I talked about, are significant risk factors. vancomycin, but given its wide use, clinicians should be aware of this risk and should monitor. Yeah, we should be monitoring patients for development of nephrotoxicity. So in patients with chronic um, kidney disease, the dosing should be strictly based on estimated creatinine clearance as the Cockcroft Galt, and that takes into account gender. And we have so many online calculators that we use to. Right, the next medication is the fluoroquinolone ciprofloxacin, which has been reported to cause acute interstitial nephritis and crystalluria. So it crystallizes in alkaline urine and could be avoided by making sure patients are volume replete, taking a lot of fluid. And all right, so from the antibiotics, let's go on to NSAIDs. So NSAIDs are widely used to relieve pain and signs of inflammation. So prostaglandin inhibition mediated by NSAID explains many of its renal complications. Endogenous prostaglandins play a significant role in maintaining normal renal physiology. The prostaglandin induced renal vasodilation is critical for maintaining adequate renal perfusion, and NSAIDs impair this renal vasodilatation and alter renal hemodynamics. The acute kidney injury can occur with either non-selective NSAIDs or selective NSAIDs, like celecoxib, which is COX-2 specific. But prostaglandins are inducing pain or implicated in pain. So if you reduce the pain, but then it will inhibit it, and it has other effects on the GIT and even the renal tubes too. The kidneys too. So prostaglandins, they play a role in stimulating renin and angiotensin-mediated aldosterone release. So the renin-angiotensin aldosterone system stimulation activation is influenced by prostaglandin also. And I hope you remember the entire pathway. So renin is being secreted by the kidneys. It converts angiotensinogen to angiotensin 1, and then angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme in the lungs. And then so 2 can cause vasoconstriction and can also go to the adrenal glands to release aldosterone, which will bring back cause sodium reabsorption and also go ahead and increase blood pressure. So prostaglandins help influence or plays a role in stimulating this renin-angiotensin aldosterone system. And so one thing that linking them up is that NSAID or non-steroidal anti-inflammatory drugs mediated prostaglandin inhibition can result in these metabolic acidosis or even hyperkalemia. Yes, hyperkalemia. Right, so with ACE inhibitors and angiotensin 2 receptor blockers, these are groups of drugs which are widely used in the treatment of heart failure and congestive cardiac failure, congestive heart failure. Angiotensin 2, it constricts both the afferent and efferent arterioles, but the effect is more pronounced on the efferent arterioles, and the net effect of angiotensin 2 is that it has increased intraglomerular pressure. So ACE inhibitors and angiotensin receptor blockers antagonize the activity of angiotensin 2, thereby interfering with the renal autoregulation of the glomerular filtration rate. So in certain situations, the loss of autoregulation could precipitate acute kidney injury. Right, so that is for these medications, the NSAIDs. For antiviral agents, some of them, some of the antivirals possess nephrotoxic effects, and drug like acyclovir, foscarnet, antiretroviral drugs, um, some of them possess these nephrotoxic effects. So for acyclovir, high dose of IV acyclovir can induce acute kidney injury secondary to crystal precipitation in the renal tubules. And nephrotoxicity can be prevented by low dose infusion and slower rate of infusion. For foscarnet is nephrotoxic by inciting acute kidney injury, so it can also cause significant electrolyte abnormalities like symptomatic hypocalcemia by chelating the free ionized calcium. For antiretroviral drugs, the most nephrotoxic of the antiretroviral agents is tenofovir, which is a nucleoside reverse transcriptase inhibitor, and this agent can cause acute kidney injury with or without proximal tubulopathy. So the acute kidney injury results from direct toxicity to tubular cells. Protease inhibitors, another class of antiretroviral drugs, can also be nephrotoxic, and indinavir, a once prominent protease inhibitor, can crystallize in the renal tubules. Methotrexate could also cause that too. So indinavir can crystallize in the renal tubules, resulting in this crystal-related kidney injury. And another thing too is, or another set of drugs, antifungal agents, for example, amphotericin B. It's an agent that is used in the treatment of high life-threatening fungal infections, and it's available for use in two forms: a conventional form and a more recent liposomal form. And the liposomal amphotericin B has an improved renal safety profile compared to the conventional amphotericin B. So the antifungal action of amphotericin B is related to its ability to alter membrane permeability of fungal cells, and this leads to death. And this effect can be toxic to renal tubular cells and also result in tubular dysfunction. For chemotherapeutic agents, like I said earlier on, it plays a very central critical role in the treatment of various neoplasms. Unfortunately, they can result in serious multi-system complications. So nephrotoxicity is common with many chemotherapeutic agents, and some of the commonly used chemotherapeutic agents with nephrotoxic side effects are cisplatin, methotrexate, like I talked about, ifosfamide too. So ifosfamide too could also cause it. For cisplatin is a standard component in the treatment regimen of various solid organ tumors, and can result in a variety of clinical renal syndromes like acute kidney injury, hypocalcemia, and hyponatremia. And the main mechanism for causing acute kidney injury is a direct cellular toxic effect at the proximal tubule. Alright, so various strategies such as co-administration of hypertonic saline and sodium thiosulfate has been tried to prevent cisplatin's nephrotoxicity. And kidney function and serum electrolytes should be monitored effectively during cisplatin therapy to detect metabolite abnormalities. Alright, so for ifosfamide, it's actually an alkylating agent used in the treatment of solid organ tumors. And like cisplatin, ifosfamide also undergoes cellular uptake in the proximal tubule. So once inside the cell, the drug is then metabolized into chloroacetaldehyde. So the chloroacetaldehyde is chiefly responsible for this particular cellular toxicity. Alright, so for methotrexate is an antifolate agent widely used in chemotherapy against several malignancies. Methotrexate induced kidney injury occurs after an IV administration of high dose formulation, so from 1,000 to 33,000 milligrams per meter square. 1 gram, 33 grams per meter square. So this results from crystallization in the renal tubules as well as direct tubular toxicity. And one thing too is the crystallization is enhanced by high urinary methotrexate concentration and low urine volume. And preventive strategies include maintaining high urine output and urine alkalinization. Yeah, so making the urine more alkaline. Okay, so these are some drugs with toxic renal effects.